Hello everyone, today I will narrate the topic asthma so that you can easily solve the previous year's question and narrow Q bank of the same topic. So let's start. Asthma is a type 1 hypersensitive reaction. There is intermittent episode of coughing, which is mainly night time, wheezing, tachypnea, dyspnea, hypoxemia, decreased inspiratory expiratory ratio, mucus plugging, and severe attacks may lead to pulsus paradoxus. Triggers include viral upper respiratory infection, allergens, stress, exercise, reach hyper-responsive bronchi, leading to reversible bronchoconstriction. There is smooth muscle hypertrophy and hyperplasia, Cartman spiral, and charcoal crystal. They are asked many times. I am zooming in so that you can easily see this. These are Cartman spiral, and these are charcoal crystal, specific to asthma. In investigation, DLC will be normal or increased. We can diagnose asthma by spirometry or methacholine challenge. Best way to diagnose is by demonstration of reversible obstruction of the airway. Aspirin or NEET exacerbated respiratory disease, also known as Samter's triad or aspirin sensitive asthma. It is a combination of COX inhibition or sensitivity to aspirin, chronic sinusitis with nasal polyps, and intrinsic asthma symptoms. There are two main types of asthma, extrinsic and intrinsic. Extrinsic asthma, as I discussed till now, which is atopic and allergic, associated with atopic, drug, food allergy, onset in childhood, eosinophil mediated, IgE level will be increased. Most common trigger is dermatophagoids, and it is well responsive to inhaled steroids, and prognosis is good. But the intrinsic asthma, which is seen in adults, it is not non-atopic, non-allergic, also known as idiosyncratic asthma. It is the Samter's triad. Instead of eosinophil, here it is neutrophil mediated, and IgE level will be normal. That means negative skin prick test. Most common trigger is superantigen, Staphylococcus aureus enterotoxin. Response to inhaled steroid will be decreased short-term response, and the prognosis will be bad. So a known case of asthma patient came to emergency department with shortness of breath. We should classify according to these things. First, we will do the acute severe asthma. Any one of cannot complete sentence in one breath, tachypnea, tachycardia, or PFR 33 to 50% of the period or best. It is acute severe, any of the. Now see the tachypnea. Here is tachypnea, but in life-threatening asthma, there will be feeble respiratory effect or silent chest. In acute severe asthma, there will be tachycardia, but in life-threatening asthma, there will be bradycardia. And here the PFR 33 to 50%. Here it is less than 33%. And there will be exhaustion, confusion, or coma. ABG will be very disarranged. Sinus may be seen. This is life-threatening. And no feature of acute severe asthma is moderate asthma. And if the in patient the PSO2 is rising, it is near fatal asthma. So first line treatment for life-threatening is intubation of the patient. Best management in the life-threatening asthma is immediate endotracheal intubation. In case of severe asthma or moderate exacerbation, we can use with nebulization and see the response and then treat accordingly. Overall treatment of asthma consists of bronchodilator and anti-inflammatory. In bronchodilator, there are beta-2 sympathetic mimetic, salmeterol, formoterol, methylxanthine, theophylline, anticholinergic, ipratropium, tiotropium bromide. And in case of anti-inflammatory, the corticosteroid inhalation or systemic, beclomethasone, budesonide, fluticasone, and here prednisolone, hydrocortisone. Leukotriene antagonist, montelukast, dapiglukast. Mast cell stabilizer, anti-IgE, anti-interleukin 4 receptor, anti-interleukin 5, and anti-interleukin 5 receptor. These are commonly asked. These are being asked in recent time in huge number, so remember the names. In marrow pulse PM2453, you can read the GINA 2021 guideline. It is free for everyone. You can access freely. Now, one important topic: brittle asthma. It is a type of severe asthma where the patient has very severe, very serious, and often life-threatening attack despite appropriate therapy. It is a two type: type 1 and type 2. Type 1 is PFR reading, a persistent pattern of variability. But in type 2, generally normal or near normal PFR reading, but few unpredictable exacerbation occurs without an obvious trigger. The treatment for type 1 is oral steroid, infusion bronchodilator, salbutamol infusion for example. Dietary exclusion of allergen may be helpful, but in type 2 the treatment is subcutaneous epinephrine. It is asked very commonly. So that's it. Now you can easily solve the Marrow question bank and PVSS question from the asthma. See you next video with another PVSS topic.